Good afternoon, everyone, and thank you very much for coming today to our BioBasics Research Seminar. I'm Judy Geffen, and I want to thank the Research Administrators Campus Committee for making the suggestion for today's speaker. I want to thank the development officers and the Office for Research Administration, and to Dion and Rosalie and everybody here who helps make research happen at the David Geffen School of Medicine. We're very grateful for your efforts. And we're pleased to present this seminar series for you, and it's really fun to hear about all the diverse activities that our faculty members are engaged in. So today's speaker is Dr. Amy Waterman, and she has a Ph.D. in social psychology from Washington University. And her particular interest is something I don't think we've heard about in this forum before, and it's all about patient education and behavior change, and in particular in the setting of organ transplant. And she rose to the level of associate professor at WashU, directing this program, and the foci were to expand access to transplant, reduce racial disparities, ensure that informed decision-making was happening, and to ensure that there was adherence to the medical necessities involved in a transplant, to promote paired donation and to increase living donation. That's a very ambitious goal. We were fortunate to recruit her here in 2013 to the Department of Medicine and the Division of Nephrology. And she has founded her Transplant Research and Education Center here at UCLA, which you're about to hear about. And their goal is to translate the findings that are made in clinical settings and in translational research to the actual patient and the family members, so that, again, the disparities are reduced, informed decision-making can be made, and there's a maximum benefit that ensues to the patients and families that are participating in organ transplants. Her research has been supported by over $12 million in grant funding, and she has 60 publications, so she's accomplished quite a bit in this area. But I was particularly interested to learn that she founded an educational resource called Explore Transplant. And this is a nonprofit that trains and equips dialysis providers and nephrology staff to help kidney patients and their families make informed decisions. This is really impressive. Since 2009, approximately 1/3 of all kidney transplant patients have participated in the Explore Transplant program, so quite an accomplishment. So it's my great pleasure to introduce Dr. Amy Waterman.
Hello, everybody. Happy lunchtime. So the first thing that I want to do, so hold on, I need one of your hands. Put your hands up if you have one free hand that you're not eating a wrap with, okay? So here's what I say about research. Research is a hand, okay? So you meet people like me and we get a lot of credit, but there are so many fingers on this hand that are in this room working in other areas, right? So there are people that are working in grants, there are people that are sitting there surveying patients every day, there are people that are helping to submit papers, to deal with meetings, hire people, all of that, right? So one of the things I want you to know from our side, the PI side, is that if we get it, and if we don't, you usually yell at us. But the thing that I am really grateful for, I have a lot of people. So the people that work with me directly on anything, could you raise your hand right now? Anybody who's working on me? These people in the room are the multiple hands that are here, both to represent me on an everyday basis. So I'm really standing in that group, and I want you to know on behalf of your PI, even if they haven't said it, that this is why we're all here today. And I'm really excited to talk to you about this idea. So this is a bold idea that I am coming to you now, talking to you about the research that I've been doing for over 15 years, but also that I brought it to UCLA. And the thought is maybe we could work even more broadly than just an individual PI. Maybe we could create a collaborative. And I'm going to talk to you about this today. So I don't know how many of you guys have ever seen a kidney out of your body or anyone's body, But this, it isn't too bloody, don't worry. But this is a kidney in a bucket of ice. There are amazing transplant surgeons here and an amazing healthcare team that work with patients and work with either people who pass away or people who generously want to donate an organ. And they are able to get this organ out of one person and put it into somebody else and figure out how to make that work. I think that is pretty amazing, right? So the thing, though, to me, as a person who works in education, is I'm actually really passionate about the lives that are about to transform when this happens. Okay, so I'm not a surgeon, and I don't know how many surgeons are in this room, but most of us who work in research usually aren't. But the thing I am really moved by, like I'm even teary now, is that these people get 7 to 14 additional years of life back when this happens. And if you look, they're just ordinary people. They're not like, you know, anybody particular. They're all races. They're people who have families. The woman up there got her kidney from her son, who's wearing the green shirt. This is a dad with a soccer ball who got a kidney from his daughter. This woman up here got a living donor kidney from a coworker. And so the coworker, the donor is in white, and the woman up there, she put an email out and said, I'm in need of a kidney, and the woman said, I can do this. Isn't that amazing? This woman is running marathons with her kidney pancreas transplant. This group is able to travel in their RV all around, not having to worry about dialysis, right? There's a family here that the dad is able to go back to work as a carpenter. His girls don't have to work. He's supporting the family again. This is a family that the wife has her kidney and they are going to their church. And this guy's drinking a lot of water because when you need a kidney, you can't drink a lot of water. So that's why we do it. But here's where it looks on a level of data. So if you have a kidney that doesn't work, one of the things to think about that I didn't understand was that often people don't urinate anymore. Okay, so I know it's gross, we're having lunch, but anyway, that's as far as I'm gonna get to. All right, so the key is that if that happens, think of the bad stuff that you eat. You know, you eat a lot of sugar or salt or potassium someday, you drink a whole lot of water, you can't get rid of it. So what happens is you either have to have a machine filter out your blood to take out the extra liquid and the salt and potassium that are in there because your kidneys aren't doing it, or you need to get a substitute kidney that's working all the time. Make sense, simply put? So basically you can get a kidney from somebody who passes away or somebody who's alive. And the thing to know is in the first 5 years after your kidney stopped working, if you're able to get a deceased or a living donor transplant, the chance of you being alive is 76 to 85% compared to only 37% of people on dialysis. So if this is my mom and her kidney stopped working, I want her to be on this side of the table, right? And I'm really passionate for patients that I care about that they have that access too. So I want to show you this idea though. I'm going to talk big today. But it's cool, there's a lot of people here who can see, and I want to talk about a national view of transplant, a UCLA and UC system view. I want to talk about clinical transplantation models of success that help make this happen more often and where we might go next. So let's talk about the national view of kidney transplant. So in the US, there's 637,000 patients that have kidneys that don't work. So here's what people tell me. No one cares about your disease. It's a small number of people compared to like cancer, right? And I don't take that personally. But here's what's interesting about this one. Actually, hold on. So who cares about these 637,000 people? First of all, I do. And there's many, many people at UCLA that do and across the UC system. But the people that are in this group are people that have had diabetes and hypertension and polycystic kidney disease for a long time. And those diseases they've attacked the kidneys. And so the communities that are more likely to have diabetes and hypertension are minority communities, African Americans, Latinos, Asians, all of whom are more likely to have ESRD because of these diseases. So then what happens is they've got to go get care at places around the country. So the green dots here are the dialysis centers around the country. Isn't that amazing how many there are? This is like a Christmas tree map here. So you have the green dots that are, if you need to have your blood filtered every other day, we've got to find you a dialysis center nearby, right? Because you've got to go for care every other day for 3 to 4 hours. So that's why there's so many, 6,000 of them. The stars are the transplant centers in the country, and there's only 250 of them, many of which are on the UC side. So the thing is, if transplant can work, it's a win-win-win proposition. The patients live longer. The patients have more freedom and a better quality of life. They're more likely to continue to work and be insured. They can go and do what's important to them. They can have joy. The things, they always say, the thing I hear is, transplant got me back to a normal life. They just wanted the simplest normal pleasures of your life. And the other part that's amazing though is it's actually cost savings. So compared to every other day treatments for dialysis, which are covered by Medicare and insurance, imagine if you have one surgery and then you pay for the drugs afterwards, but you don't have all these medical meetings, right? So it's the best thing for us as taxpayers because we pay for a lot of this. And then also it's revenue generating for medical centers. So the more people who come in to get transplants, especially those who have living donor transplants, the more revenue that we can make. So what I was saying before is that even though we have a lot of patients who are Black or Hispanic that have ESRD, sadly they're not as likely to get transplants. And one of the things I'm really passionate about is that everybody in the United States should have equal access to the best treatments for them. So what's really interesting to me is although they're 3.4 and 1.5 times more likely to have ESRD, they're less likely to receive transplants. So my lab works a lot to work with these communities and to try to overcome the barriers in access so that they can get a transplant. One thing that I see though, it's not about the UC side. In every transplant center in the country, Black patients are less likely to receive a living donor kidney transplant. And there are a lot of reasons why. We can talk about it, but a lot of socioeconomic reasons, psychosocial reasons, insurance reasons. And I want to show you in an LA sample something simple that might point to this. So we're currently running a study, and this is some preliminary data from it. But we ask our patients coming in for transplant. I want you to look at the second pair here. We said, how long are you able to live in your current situation, where you work, driving, your apartment, if you lost your current source of income? And we found that no matter what race you were, only about 50% of the patients that we're meeting here at the UCLA Transplant Center could live for 2 months or more. They only had 2 months or less of savings and they would have to change something. So they're very precariously balanced financially. The second issue is that in looking at who doesn't have access to a vehicle, either you or someone that you care about or know well, 41% of the Black patients who are coming to our transplant center, which we make them come in for lots of appointments, don't have access to a vehicle themselves. So you can start to see and feel what the lives of these patients might be like. Many of them have to stop working because of all of the dialysis treatments. So this is a group of people that could easily get left behind in dialysis centers if we didn't do something to try to help. Now, if I tell you your mom needs a transplant, what your mom would have to face was that she would have to first learn that transplant might be something that she could do. She'd want to call a transplant center, one of the 250, to begin evaluation. She'd want to attend transplant appointments and complete the steps, all the medical tests that they require, get listed for transplant, complete the yearly reevaluation, find a matching kidney, so wait. Do you know how long it is to wait for a kidney in California right now? How many of you think it's 3 years or less? No one. 5 years, 4 and 5 years. 4 and 5 years, okay? 6 to 7, okay? 7 to 10, okay? 7 to 10 years. So here's the thing. Remember the slide I showed you at the beginning about how it's 37% of people are alive after 5 years on dialysis? If they're going to wait 7 years for a deceased donor kidney in California, it's shorter in other places, they might not be alive. So now the thought is, well, now you may need to talk to your family and friends about living donation, right? Now that's another big and complex, confusing thing. And then finally, you'd get a transplant and you'd have to follow all the medication and health recommendations to keep your kidney working. So just like whatever health area that you're working in, you could see that patients are learning to doing what they're supposed to do, to getting the ideal treatment, to then keeping it, right? So we're all dealing with that. Now, if you're on the living donation side, so now you're like, my mom needs a transplant. Could I ever be a living donor for her? We actually had this happen. So my lab had an intervention that we didn't expect. So we do all this educational intervention. We had an undergraduate student whose mom had kidney disease who came to volunteer to do surveys with us. After learning everything, she's now donating to her mom. So one of my RAs is now making a difference for her mom. But she had to first of all learn about the risks and benefits of living donation, talk to the patient and say, I really want to do this for you, call to begin evaluation. She had to come in and attend all the appointments and pass all the tests and donate, and then make sure she's monitoring her health going forward. All right, so here's another hilarious thing. So there was a study done that said, how are people learning about living donation across the country? What's the most common way? Okay, is it the news? Is it, Amy, here I am, I'm an educator, you're learning it from me, the whole thing. Do you know what the answer was? Grey's Anatomy. So basically, dramatic television, usually the worst case scenario dramatic television, is the current way in which a lot of people are getting their living donation education. Has anyone gotten an email about how someone woke up in a bathtub with their kidney removed and the bathtub full of ice? Yes. This email has been going around from my area. It is not true in the United States of America, FYI. It is, but anyway, the point is that these fear-based things are what our public conversation about transplant is. So one of the things that I'm really passionate about doing is maybe we should bring that conversation into a healthcare space and to make sure that the information is accurate. So if your mother ever needed a kidney, you wouldn't be hearing fear-based information. But if you think about that, that's the general transplant information to the public. But then what also happens as patients' kidneys start slowing down is that they start meeting people in nephrologists' offices or in dialysis centers, and they're getting education about transplant there, hopefully. They're also moving into, walking into a transplant center here, and they say, have you ever thought about getting a living donor kidney? What about after they're waitlisted? They're waiting, it's been 2 years, their kidney number isn't coming up, maybe now I'm gonna be open to living donation. And then afterwards, we have to make sure they're doing everything right. This is the continuum in which I work every day and do a lot of interventions. Now, I wanna show you the situation though. How many people want a kidney right now, today? Actually, as of 2/27/15, 101,000 people, okay? So these are the people waiting right now. And I think about, these are the people that echo for me. I don't know where you feel about what you love about what you do, but these are people here who are, I'm intervening with, but also that, want a better quality of life. And the thing to know is look how many patients of color are on that list. The other part is how many of them have a success. So let's look at 1 year. So in 2013, which is the most recent source of data we have, 29,000 people got a call. Right? A really cool call in the middle of the night or, from a transplant center and said, we've got a matching kidney and we want you to come in and we're gonna give this to you. And if you'll notice, only 6,000 of those calls last year were living donor transplants compared to deceased. Now, 12,000 patients became too sick to be eligible for transplant or passed away while they were waiting for the call that never came. So the key is, all right, well, maybe we can increase the number of deceased donor transplants that happen. How many of you have a pink dot on your card? Like you've decided to do that, okay. So you guys are an amazing group of people, the people that are the pink dot group, that you've basically said, in the situation where if I pass away and my organs could be helpful, I wanna make them available. So thank you for doing that. There's over 100 million people. So you'd think, well, we got it handled then, right? The problem is people have to pass away in a way that they can donate. Right? Yeah, right. You're all alive. Exactly. So thank you for being alive. Really enjoy your life. But anyway, once you're done and are moving on, the key thing to know though is that there aren't more people dying of car accidents every year. Does that make sense? The same amount. So it's stabilized. So since 2003, you get the same number of people. It's the transplanted organs, the 20,000 here. So we're not increasing that compared to the line, which is the number of people who need them. So thank you for being a part of the Pink Dot Club. Consider being part of that if you're willing. But the thing to also know is that living donation rates aren't going up either. So going back to the 6,800 people, look how it's been varying since 2002. We're actually worse off than we were in 2002, okay? So the only room to help these 101,000 people to get transplants is living donation, okay? More than what we're already doing. I honor fully what we're doing for deceased donation, but the only space for improvement is living donation. And so what's happening now, if you're a family member of somebody, is that patients who come into transplant centers, we're talking to them about living donation. Would this be something you'd be open to? Would you be willing to talk to your family and friends? The big issue is so let's say I say to you, okay, we're all gonna lose weight, okay? We're gonna have to go to a gym, we're gonna have to eat healthy, we're gonna do all this. All of that is under your control, right? So if you decide to get on a treadmill, you can get on a treadmill, and you can eat the foods that we're recommending that you eat. In the case of living donation, it's a very, very interesting behavior because it takes two people to have a success. Does that make sense? So if I say to all of you guys, well, one of you be my living donor. I'm really nice. You guys are really nice. Let's find one. If you all say, no, we don't want to do that, I don't have a living donor kidney. Does that make sense? So what happens is you have recipients, potential recipients, who would really like a living donor transplant, but don't know how to even tell you guys. I feel so vulnerable, they say. I don't want you to reject me. I don't want to pressure my kids. All these things, understandable things, right? Then you have the donors who didn't come to the transplant center and they don't even know. And they watched Grey's Anatomy and it looked pretty scary, right? So we have an opportunity to educate and intervene with a dyad, two people, and or to do one or the other or all of that. So a lot of what the work that I do is to design educational interventions and to test what works for different communities and to see what delivery systems work and how we can get education to different people. But here's what I think is so cool. So remember when I said that there's only 637,000 people who have end-stage renal disease, and who cares about them because it's not as big as cancer? This is a disease that we can actually eliminate the entire organ donor shortage if we were all working together. You know, with cancer, maybe somebody else will have to come and see if that you can eliminate cancer. That's not for me to speak about, but one of the things that I get is I think there are at least 102,000 generous people in the United States of America. I think there are many people in this room that are generous people. I think there's generous people everywhere. So the thing that's interesting, with 318 million people in the US, I bet we could find 102,000 generous people if we did our jobs right. And that's what I'm up to, fundamentally speaking. So I have to tell you something funny. So I did this slide and somebody said, well, you know what? The 318 million people, some of them are children. So they couldn't donate anyway. So I would now like to qualify, let's say there's 100 million children. Now there's 218 million people, and I think still there's 102,000 that might be willing to donate, eliminating the children, okay? So the thought I have, though, is we've got to get to work, like we do. The transplant people are working hard. The clinical people are working hard. They're amazing. I am so honored to be in the Department of Nephrology. But the thing is, how can the research side help, right? That's why we're here. Everyone that I ever interviews for a job for me, the first thing they say is, I want to help. How can I help the patients? So here's what I think we need to help more. I think we need to be doing state-of-the-art clinical research to understand and improve understand all the issues affecting transplant and improve the outcomes. We need to be reducing disparities. Everybody needs to be getting education equally. We need to make sure that anyone who's in a dialysis center or in a community nephrologist office who wants a transplant shows up at the transplant center as soon as they can, right? We want to get them so that they aren't lost in our system. We want to try all sorts of interventions, whether we're looking at a patient intervention, a media intervention, working with the provider pipeline of care to try to improve that. However we're doing that, to see what works. How do we find the living donors? They aren't coming to our transplant center, right? So how are we going to find the people who care about the person that we're meeting? Now it gets really interesting, and these are the questions that I think a lot about. And finally, how can we reduce the shortage of kidneys for transplant? So one of the things I want to say, I want to back up for a second, and I want to talk about research as competition. So you might meet somebody like me, and then the next time you meet somebody else is interested in something similar. And you say, well, there's Amy, but then there's that other researcher who also wants to study something, and we're all in competition with each other for funds. And you know that, people who are working in the fund side of things. I actually think it won't work anymore, especially in this funding climate, to have us all be at war against each other. I really don't think that. I think it has to be a jungle gym. And I think the key here is there are some experts in everything across UCLA and across the UC system. And to solve a problem like this, to try to eliminate the organ donor shortage, I think we've got to get the best of everybody, including you all. And we have to figure out how we can be working to create system. So Sheryl Sandberg in her book Lean In said this is the stable system because there's no one leader, but everybody's in positions of power. And a lot of people, we can dance and be more creative as things change, okay? So this is the model that I'm talking about. So the thought I had is, could we create a clinical research system where the best of UCLA clinical and research leaders could work together? Could we partner across the UC system? Now there's an interesting idea that, depending on the person I talk to, is either really innovative or really naive. And finally, could this level of partnership result in more federal funding, research support, and maybe even reduce the number of people waiting for organs? So this is what I've been inquiring about with a lot of important people, much more important than me, in the last few months. So I want to show you the UCLA side of it. All right, so there are multiple UCLA transplant programs in operation now across our system. And the Ronald Reagan UCLA Medical Center is amazing. We're all proud to work here, and in the top 5 hospitals, and UCLA and is in the top 10 for both nephrology and urology, which is also amazing. I'd totally come here if we needed anything regarding what we do. And I don't know if you guys know, but there's a new transplant center opening here this year. So there's amazing energy around transplants. But what kind of good do we do? We, in 2013, that same year, remember that 28,000 people got organs? 1,119 of them were in one of the UC system. So these are people benefiting here directly in our home base or in our neighborhood communities. At UCLA, 166 people got a call in the middle of the night, said come in for your deceased donor transplant. 122 people had their family members and friends donate. So it's pretty amazing. And the thing also to know is that the diversity of our patients in the UC system is even more diverse, I think, than many other places, which is important in terms of helping them, but second, a really interesting area where we can be studying things that other people couldn't study. Now, looking at our waiting list, what's interesting is in California, about 18,000 people, I think I pulled something out, but I think it's about 10,000 of the 102,000 people are at one of the UC system. So 10,000 people are waiting for a kidney right now in across California within a UC system. Now, if they can get a kidney, we can treat them better than other people can. So according to the reports about excellence, UCLA is always better than the national averages and has been there for 15 years. So this is definitely a good place. They can keep your kidney for a really long time. And UCLA knows a lot of things about a lot of things. So if you needed people with these expertise, they are here already. We also have some of the largest databases of transplants and donation. And here's what's an interesting research side. So I don't know how many people are in here looking at the number crunching part of research, but transplant, since it's funded by Medicare and by insurance, we actually have every single person who has had their kidneys failed in the country. We have the ability to look at data from UCLA, but link it to 100% of people who've ever had ESRD, gotten a transplant, things like that. That's a rare research opportunity. We also have a network of pediatric centers where we can conduct research. This is one of the largest pediatric centers in the country. And there's all sorts of things happening where kids are supported by their parents for a long time. I don't know how many of you are working with adolescent-related issues, and then now it's time for them to take over all the drug treatment regimen and all of that, and then kids aren't taking it because they're having fun in college or whatever they're doing, and then they lose their kidneys. So there's all sorts of issues at the point of transition for kids to adults. But the other part is there's lots of partnerships across LA. So my lab, we've just gotten permission to do interventions within 63 of the dialysis centers that are in the LA area, referring into UCLA and other places. Another thing that we have that I think is really great is what are the questions that we want to figure out that involve diversity and disparities and socioeconomic issues. My staff are always coming back and telling me things about challenges that my patients are facing and how this issue is something we should now consider. The other part is there's something really cool. Do you guys, have you heard of the chains, the transplant chains? Yes. So that's an amazing thing that is very, very important here in urology. Jeff Veal is a collaborator of mine, but and many people are working on the paired exchange program, but it's amazing now that you could donate not only to your mother, but you could be part of a long chain of multiple people to benefit the greatest number of people. You also have experts in ethics here. I actually just went to Ontario to help with setting up transplant education in the province of Ontario. UCLA doctors are going to bring surgical training expertise to other countries. So it's amazing what people know how to do here. And then you have the General Internal Medicine Health Services Group, who I've been privileged to be able to hang along with. They let me come to all their meetings. And Keith Norris is a national expert in disparities. We have health policy experts here. But imagine all the people that know how to measure and intervene in all these different ways, applying what they know to transplant, right? So imagine we're building a collaboration. So we're watching what's possible at UCLA. So I want to actually also say that we could look at, we're only talking about kidney transplants, but here's what also happened at UCLA in the last in 2013. They're liver experts, heart experts, lung experts. We're a multi-organ transplant program, and that is rare. Of the 250 transplant centers, not everybody actually looks at all of the organs. So there's just so much of a rich area to be explored here. And I want to fully acknowledge that lots of people are exploring it. I just arrived. People have been exploring these kind of questions for years. But the key is we're all working individually. Remember those ladders? We're all working individually. And the question is, could we work together more effectively? So I wanted to show you a model of success. And this is a statement that's a little bit controversial, but after meeting with a lot of people are in agreement with me. The federal funding that UCLA and UC-affiliated transplant centers receive is not consistent with the number of transplants that occur here or their national reputation for clinical excellence. Okay? So here's what I see. There's a gap. There's a gap in the number of living donor transplants that we need to be having across the country. There's also a gap in terms of the amount of funding that we could be bringing in to study these questions. Make sense? So let's look at how people get that money. And so you guys may be part of centers or collaborations, and I'd love to talk to you more if you would, but my feeling right now is that I'm a researcher. I have a lab, a bunch of staff, and we work really hard. A lot of people come to me and they say, we'd really like to do research with you, but it's difficult to have time to nurture, grow all these people. They're clinical staff who have great ideas because they're right there seeing it happen, and they don't have time to do the research. They don't have any research staff. And then finally, we have a nephrology training program that's called a T32, but it's not transplant focused. So there is a program in Northwestern called New TORC, and the conclusion is bad name, New TORC. Don't you think TREC? We're trekking with the patients. Transplant Research Education Center is better than New TORC. However, we have to give them full credit. They are very, very successful. And I want to look to their example as a model to see how we could bring this to UCLA. So they work on issues like economic issues affecting transplants, quality of life, patient safety, informed consent, disparities, access and allocation of organs, and medication adherence. And this is what's amazing. And if you think about the good that they're able to do with this money. So they've submitted 81 grant proposals from 2002 for 5 years. 39 had been funded for a total of $12 million. Okay? How many people did that? 40. 40 people worked together. And so the thing that's interesting is somebody like me had a bold idea. They were able to get funding for it. And within 3 years, it became fiscally sustainable. And they were able to publish 60 manuscripts and 166 national presentations and continue to do excellent work in our area. So I don't know how many of you guys get funded by grants or watch how the grant patterns go, but I want to show you how they do it, because this to me is the answer, the secret answer that they were nice enough to publish for us. Okay? On the left is a T32. That's a fellowship grant for getting people trained to add to the research team. Over here, they got a collaborative development initiative funding, which means that UCLA gave them money, but it was Northwestern in their case. Then over here, they got a U01 grant, which allowed them to get $3 to $5 million to really start to launch what we're doing. And then what you see over here are all these little grants that many of you might be part of with your different investigators. R01s, R03s, R21s, HRSA grants. And so what happened was they just kept building over time their research portfolio, and they worked as a collaborative team. Here's what's interesting financially. So they started on the left and this line is what Northwestern gave them, a $900,000 startup amount. And they kept going, and what happened was by here, they made $6.5 million in directs and 1.5 indirect rates by 5 years. So this is what we do. And here's the thing that you have to see. So where PIs come down and grants people come down, I think, is what does this make possible? Like, why, for the people that are like every day doing boots on the ground work, surveys, writing, all of that. This gives us the ability to have the next interesting idea, the out of the box thing, the novel and important big initiative, the things that are figuring things out, the research study that's going to answer it for the country. That's what this money is. So that's how it all fits together for people who don't see every level of it. The other part about what that money makes possible is collaborations. So when you're over here on the left, which is where it started, these are all little PIs with their teams. And what starts happening is we all start helping each other get smarter. So I'm smart, you know what I mean? My team is smart. We're working within our team, but that's not enough. You actually have to work with groups that don't know anything about transplant, for example. So they go, we don't know transplant, but we know economics, or we know disparities. So let's apply what we did in disparities in AIDS to disparities in transplant. That's why the value of what you're doing in the healthcare system and the university, we start seeding each other. And by the end, think how much smarter we are when all of these experts are working together. You can tell, transplant, healthcare studies, engineering on the left. Okay, the other thing I want to say is I'm competitive. I think anybody who's here. So did you know that there's a kidney research center called the UKRO that USC is building, that they want to have happening in 15? This bothers me. They actually didn't call it the USC. They actually credit that it's part of UCLA, although everyone I met, they don't know about it as well. But the thing I get is, you know what, we're great. We should be bragging about us. So where could we go next? So this is my question. Could we copy this model, right? So could we bring in, and here's what I think is amazing about UCLA and the UC system. We trump in numbers of transplants everybody. And we have the diversity of the country here. So if there was a center here we could put everybody together, we could be answering the questions that everybody wants to know. And we have enough people and patients and donors and transplants to be able to answer anything. So how do we use the model that's already there? So this is my proposal, TREC. This is what I was hinting at before. So the Transplant Research and Education Center is what I'm proposing that we call it. We're bringing the new TORC model to UCLA. And this is what I've been doing. I've been meeting with some amazing people. We've been talking about what a clear 5-year center vision is. We've been looking at who the leaders should be. We've been looking for people who this appeals to them or their work could be included under the umbrella of this, and they could bring their expertise to expand this, the mission. We've been looking to develop training opportunities and research support staff for staff that love the area of transplant but don't know research. Anybody in that role that you're the research coach for the clinical teams? Anyone have that? Okay. So then we're looking to set up a T32, but then also we're looking for the financial and research infrastructure so that we can do this, so that we can launch it. So a lot of these people who some of you know or work for have said we champion this. We're happy to bring our vision and support for this initiative. I'm incredibly grateful it wouldn't have come if these people didn't say yes. But here's what I see. What if at UCLA we were about understanding the critical, modifiable patient, provider, and system barriers affecting deceased and living donor kidney transplant rates and outcomes, and designing interventions to overcome or improve them? Like, that's what, you know, I've given my life to. It would be an honor to continue to do so. How could we do that? What could be the ways in which we attack this? Okay? Here's what I would say. We've got to make sure anybody who needs a transplant has the best transplant outcome possible, that they keep their transplant, that they live the longest that they can, that they have the best quality of life. We need to make sure we have enough living donors. How do we need to be expanding the living donor pool? Chains, new people, all of these different things. There's so many interesting ethical issues to be studied about this. What about racial disparities? How many of you guys want to make sure that every black patient who wants a living donor transplant can get one? That's me. How many people want every Hispanic patient wants to get one? That's me. How about Asians? Yes. White people? Yes. Anybody else? Everybody, right? Okay? There's equity. You know, it's ridiculous. It's the United States of America. Okay. So then you go to the education pipeline, and I think this is really, really cool. The key here is we line up everyone who's providing care for these patients. People in the community, the dialysis centers, the dialysis, community nephrologists, transplant centers, and we have all of us work better together to be referring people in, educating them consistently, helping them as kidneys slowly fail. And then finally, there's so many smart people. There's so many economic issues that need to be studied here to figure this out. This is one of the highest costing healthcare areas because we cover all of the ESRD care for people. Once your kidneys fail, you're totally covered by Medicare now, no matter if you have Obamacare or not. It's been covered since the 70s. So this is a very expensive thing. So there's a lot to be studied in these areas. Now, structure-wise, we're putting together an administrative core and experts who work in all of the balls. So these are the balls that I just mentioned. So if this appeals to you, let me know. I don't know if any of you, I spoke about Jeff Veal over here and Keith Norris. They're my partners in crime. But again, standing in collaboration, the thought is Amy's in nephrology, Jeff's in urology, and Keith Norris is in general internal medicine. So now you get people sourcing the research teams coming out of all of those areas and bringing the energy of people who get all of it together. So we're working on that. And you've met me a little bit. I'm trying to think. The thing you need to know about Keith is Keith is amazing. Keith, he is a passionate champion for disparities, and he is leading the country regarding disparities in kidney disease. Jeff Veal is doing the paired exchanges with Dr. Gritch and all these other people who are, everyone, he's done more chain transplants than anyone, I believe, like over 100 here. So that's amazing and beautiful what they're doing. So then, how am I gonna sort this out? So then it comes down to dollars and cents, right? So just like you guys, I'm dancing with dollars and cents all the time too. So the key is we're looking for the kind of startup funds that New TREC had. And we're also looking through lots of sources. I've met with the foundation people, I've worked with the CTSI, people have been really receptive. But also we're seeking external funding, the large grants. And so people have been generous enough to say they'd partner with me on creating these. I'm also doing R01 and R21 grants, just like many of you may be doing. But here's what I get. Here's the proposed success. So by 2020, 5 years, New TREC took 4, we might take 5. In 2020, I think we could become an internationally known research and education center in transplant at UCLA. And I think it could be something that benefits the whole UC system. I think there could be at least 100 researchers, collaborators, advisory board members, and trainees across the UC system that are learning how to explore and answer these questions and make it better for our patients. I think we can definitely win 12 to 20 million. I've won 12, I think 17-ish million now. So let's see if we can sort this out. That becomes a challenge for me and my teams, who I stress out. And then, but the thing also, and it was interesting, Gabe Danovich and I were talking about this. Gabe is the clinical head of transplantation. And he said, I said, we could publish a lot of papers. And he said, we want to publish papers that influence the national and international course of transplant and living donation. We don't just want to publish papers. So I want you guys to get that, like the work you're doing, however you see it, it's to influence the national and international course of healthcare. That's why you're here. And then finally, I think that very practically speaking, we should be increasing clinical and research partnerships across the UC system. Various people are willing to work with me now that I'm here. We need to increase efficiencies between referrals into our transplant center so that patients aren't getting left outside. We need to be improving informed decision making. We have a lot of elderly patients that need transplants. We need to help them learn about the complexities of all of this and feel good about the decision that they make and live as long as they can. And finally, wouldn't it be cool? So let's go back. 10,000 people are on the waiting list right now. 5 years from now, something you did, something I did, something the transplant center did. What if, how big could the list be? What if it was only 5,000? Wouldn't that be worth doing? Wouldn't that be worth getting up in the morning? So that's where we stand, and it's really an honor to be here. I'm open. This is not a lockdown idea. This is an organic idea. But I just want you to know that every day that you're sitting there in the lonely office that's kind of grubby, I don't know about you guys, and you're thinking, I wanted a window, I wanted a better chair, that what is possible here is that somebody is going to be alive because of something that you helped us learn. So thank you so much. It's an honor to be with you.